I'd like to welcome everybody. Thank you for coming, and I also thank the Office of Innovation and Commercialization for inviting us to speak with you and for their support as we develop this idea. We're going to talk in two parts. First, I'm going to sort of set the stage and tell you about some of the clinical context for this idea, and then Juan Carlos is going to talk to you about some of the more technical aspects of it. And the idea of our technology is a new method of analyzing blood flow in the heart in order to identify people who may be at increased risk of stroke, and then we can then direct those people to get treatment and hopefully prevent them from having stroke. So just to give you a little bit of background about us and our group, there are two of us are speaking today, but we're actually representing a group of collaborators that is, as you can see, multinational and also across different specialties, representing both cardiology and people with expertise in fluid dynamics. And between the group of us, we feel like we bring synergistic talents and expertises, and together have been able to come to this technology that we're very pleased to present with you. So first, a little bit of just background about stroke. Some of this you may already know. Stroke is the 5th leading cause of death in the United States. It causes 1 death every 4 minutes. And I think beyond that, what a lot of us, when we think about stroke, is not just death, but really the disability that goes with it, which is very profound. As a cardiologist, I always like to think that the heart's the most important organ, but I think, if I'm honest, the brain is the most important organ, maybe heart's number 2. And so, and of course, if you lose brain tissue, you can't get it back. So it's really, a very, very important thing that we do everything we can to prevent this. Now, strokes can occur from several different causes, and about 1/3 of them occur when a blood clot comes, usually from the heart, and then travels into the brain. And that's the type of stroke that we're going to focus on tonight. And so why does a blood clot form? Well, a blood clot can form for several reasons, but one of the key things that predisposes the formation of a blood clot is when blood doesn't move as much. So when there's an area of stasis, then blood is predisposed to clot, as you might imagine. And so there are the heart conditions that we're going to focus on are things that predispose the heart to have less blood motion. The most common reason that this occurs in the heart is actually due to an electrical problem of the heart. You may have heard of called atrial fibrillation. That is very common. But in addition, this can also occur when the heart muscle is weak. And when the heart muscle is weak, then also the blood doesn't move as much. And I'm going to talk to you about that in more detail. And so there are a couple times that this can occur. One time when it occurs relatively acutely is after somebody has a heart attack. And heart attack, again, is extremely common, unfortunately, greater than 700,000 heart attacks a year in the United States. And after a heart attack, the heart muscle becomes acutely weak in a local area, which is the heart a heart attack occurs when the heart doesn't get enough blood flow. And when the heart muscle becomes weak in an area, then there's an increased risk of the blood clotting there because the heart doesn't contract normally and the blood doesn't flow normally there. And actually, in a recent study, it was shown that for large heart attacks involving the artery along the front of the heart, and there are 3 main arteries that supply the heart, so this is one of the 3, 15% of people form blood clots when they look closely a month later. They actually had blood clots and they didn't know it. So the result of this is there are tens of thousands of people who are at risk of having blood clots and potentially having strokes every year as a result of having heart attacks. In addition, another important group is people with congestive heart failure. Congestive heart failure occurs when the heart doesn't supply the blood adequately to the body, and there is a syndrome of symptoms that can occur as a result. There are essentially 2 main categories of heart failure. One of them is when the heart muscle is weak and doesn't squeeze well enough, which is the one I wanted to focus on. And so here, for an example, in this picture, here's a normal heart and here's a weak heart, and I'll show you some movies of this in a minute, and the weak heart is dilated and doesn't squeeze as well. And again, so these people, because the heart is weak, and this can be for different reasons. Sometimes it can be because they have had heart attacks in the past. Sometimes it can be for other reasons. It could be for an infection. It could be something that they had as a result of a genetic abnormality. It could be as a result of a medication they received. There are a number of different causes for this, but the common pathway is they end up with a weak heart muscle. And in research studies, these people have been shown to have had 5 times the risk of a stroke as people with a normal heart. So again, this results in thousands of excess strokes per year. So these are groups that we want to target. So in order to describe this technology to you, first I want to give you an idea of what heart images look like, because we're going to be using these images in order to understand the blood flow of the heart. And the main technology that we use to image the heart is echocardiography, also known as ultrasound. This is very, very commonly used in cardiac care and essentially in all of the cardiac hospitals, cardiac clinics, and it's a painless, harmless test. Takes 30 to 40 minutes. It can be done with a portable machine, and this is a picture of a sonographer taking a picture of somebody's heart using a probe here, where they send sound waves into the body, and then the sound waves get reflected back, and then the machine analyzes them and makes an image of the heart. This is actually the same technology that's used to take a picture of a baby in a mother's womb, just, you know, little different setting, about a foot higher on the body, okay? So here's an example of an echocardiogram, and this is where the heart has 4 chambers, and for our purposes today, I want to focus on this chamber in the upper right here, which is the left ventricle. This is the main pumping chamber of the heart. And in this picture, just to orient everybody, this is, by the way, this is the right ventricle, and this is one of the valves here. And this is a normal heart, and you can see that all of the walls are moving symmetrically, and so the walls and the muscle is shown in white, and the black here is the blood. And what you see is that on an echocardiogram, we actually don't see the blood directly. So what we see is we see the walls. We can try and infer what we think the blood is doing, but we don't actually see it. And a normal heart like this squeezes out about 2/3 of the blood from the left ventricle with each heartbeat, okay? And so that's a normal heart. Now I'm going to show you some to compare that are not normal. And this is a patient who's had a recent heart attack. And this is a patient that I recently took care of. And what you can see, again, this is the left ventricle, and this area of the heart is squeezing normally. But if you start here, there's a hinge point that starts here and goes all the way around here, and this wall of the heart is not squeezing at all, okay? So I hope you can appreciate that. And as a result of that, we can imagine that the blood flow pattern in this heart is going to be much different than that of the first heart. And as a result, that there's an increased risk of blood having stasis in this area that doesn't squeeze normally. But again, we're not visualizing that directly. We can only try and infer that from these images. Okay, and now this is another patient, also a patient of mine, and this patient had a heart attack at an outside hospital, then a few months later established care with me, and I did an echocardiogram, and this is what I saw. And what you can see is he's at the top of the heart is where he had his heart attack. So this area of the heart doesn't squeeze, and then here, right there, is a blood clot. Okay, and you can see, you know, I think it's very clear to see, and it's obviously a very concerning thing to see that and to know that that's there, and again, this is somebody who had a heart attack down with it's affecting that main artery down the front of the heart, and so once I became aware of this, then I put this patient on blood thinners. And fortunately, this patient did not have a stroke, and after about 1.5 years of blood thinners, this blood clot went away. But during that time, was a time of increased anxiety for him, as you can imagine, and certainly if a piece of that broke off, it doesn't even have to be the whole thing, because some of the vessels in the blood, in the brain are quite small, it can really be devastating. And so really what we would really like to do is to prevent this before this happens, not wait until we see it and then treat it, because it's a very dangerous situation. Now here, to give you another type of heart disease, this is somebody who has congestive heart failure, but not due to a heart attack, but due to a weak heart muscle. Okay, and so here, this person has not had any heart attacks, but the entire muscle is very, very weak, and this person has severe congestive heart failure, and this person, instead of squeezing out about 2/3 of the blood, is actually only squeezing out about 20% of the blood with each heartbeat. And again, you can imagine that the blood flow is going to be much different, and there's going to be much more stasis in this person's heart, an increased risk of a blood clot forming. And finally, here's one last example I'll show you. And this is a woman who also has congestive heart failure, has an abnormal heart. This was due to a genetic abnormality that she was born with. And her heart is a little bit better than the last one. But this woman, unfortunately, actually did have a stroke. And so you don't see a blood clot in this picture because this picture was taken after she had the stroke, and the blood clot that was there unfortunately went to her brain. But the good news is she actually did very well, recovered well from the stroke with actually no major deficits afterwards. But this is this is a very scary situation. This is what we want to prevent from happening. And so we want to identify people who are at risk of this and treat them. So just to sort of summarize this idea, this problem that we've been describing, here's a cartoon to show this to you. The idea is a blood clot forms. Here's a picture of the heart. And we're thinking about the left ventricle, which is on the right in this picture. That blood clot, then a piece of that travels through the body, and then it gets lodged in one or more blood vessels. Sometimes it actually showers, and there are multiple blood vessels, and they can see when they take images of the brain that it did come from the heart. And these can cause very significant strokes. And so that's the pathway we're trying to prevent. Now, we know that we can put people on blood thinners, and if we put people on blood thinners, they're very good at preventing blood clots. But then we have to weigh that against the risk of the blood thinner, and the risk is bleeding. And it is significant, and that's a decision that we want to make in as informed a way as possible. And so what we really would like is a tool to identify the people who are at most risk of forming these blood clots who would most then benefit, and so then the treatment would be favorable for them and outweigh the risk. So just to give you some background on some research that was previously done to address this problem and look at unselected patients. This was a very large study published in the New England Journal of Medicine, so one of our most prominent medical journals. And what they did is they took about 2,000 patients who had just low ejection fractions. Remember, normal is about 60, 65%. And these were people with an average of 25%. And they half of them they put on blood thinners, and half of them they put on aspirin. And then they watched them, and they saw what happened to them in terms of strokes and bleeding. And so what you see, and warfarin is the blood thinner here. And what you can see is the number of strokes was much smaller than in the group that was on the blood thinner than in the group that was on the aspirin. But the major bleeding, hemorrhage, was significantly higher. And so because of this, this was not considered a successful treatment for unselected patients. So if we just took all patients with low ejection fractions, then it's sort of a wash, because the risk of the bleeding, which is significant, is similar to that of the strokes that are saved. So in summary, the blood thinners, they can prevent the clots, but because we don't have a tool to decide who to best give them to, in clinical practice, we often don't use them. And so our guidelines for these patients currently by our major cardiac societies and things tell us unless we actually see a blood clot, we really generally don't give them unless we really have a pretty high suspicion that one is going to form. Now, one time in particular that we do often consider this strongly is the situation that I showed you earlier, but we don't have a good tool to do it. And so I'm faced with this, and my colleagues are faced with this situation on a daily basis. And I actually saw a patient just this morning who had a very large heart attack attacking the front of the heart, had a lot of heart damage, and in the next 24 hours, I'm going to have to make this decision about this patient, and of course with the patient's input. And so the question is, again, here we have this patient, and we have to decide, should we put this patient on blood thinners? It's a major decision to make for this patient, because after a heart attack, they already go on some medicine that decreases their platelet function and increases their bleeding. Okay. Well, I'm about done my portion of the talk, so I don't see this as a problem. But Juan Carlos, let's see, yeah. Okay. So these guys. Okay. Anyway, so this is the situation. So what happens in clinical practice right now to patients like this is literally we take this picture where we don't see the blood at all. We look at the walls, and then the cardiologist, me, somebody else, looks at the picture and tries to infer what we think the risk of the blood clot clot forming is. That's a completely uninformed decision, and it's not based on any data. I haven't been trained on based on looking at a series of people who I knew formed blood clots and who didn't. And if you went down the street and saw a different cardiologist, the same patient may get a little bit different opinion, and there's significant variability because we don't have good data and we don't have a good tool in which to make this decision. And so this is the clinical problem that we are now seeking to address. And I'm going to have my colleague Juan Carlos now come up and tell you about some of the details of this.
Thank you, Andy. So the way as an engineer I approach this problem is trying to try to understand how blood is transported and mixed inside the cardiac chambers. And the first thing that one has to understand in order to get a good grasp of this process is that blood doesn't flow in the heart like toothpaste flows out of a toothpaste tube. It actually has quite a bit of inertia, and it generates, while flowing, very complex swirling patterns due to this inertia that actually generate complex mixing patterns. And remember that we're in determining the stasis, we are interested in knowing how that flow is actually going to mix the blood and how eventually that's going to lead to pools of blood that are not mixed and that remain inside the ventricle for a long time. Okay. Okay. All right. So the challenge for us was to develop a clinically acceptable method to identify patients that had increased risk of forming blood clots. And by that, we were using as a surrogate risk score the level of stasis of blood inside the ventricle. Now, as an engineer, I typically think of problems in this way, and I typically achieve an answer that is satisfactory to me when I have a method that is accurate and reproducible. But then, in talking to medical doctors, I realized that medical practice is more complex, and that typically medical doctors not only require a method that is accurate and reproducible, but also a method that is low cost, that can be actually performed at the bedside or that requires very little effort, that it doesn't take a long time to come up with an answer, that doesn't obviously pose any risk to the patient, and that it is easy for technicians or to learn how to use. And that obviously poses a number of additional challenges that we had to tackle in coming with an answer to this problem. And that's one of the reasons why we decided to go with ultrasound as our imaging tool, because it's essentially non-invasive. It compared to other non-invasive, relatively less non-invasive imaging tools such as computed tomography or MRI, it's non-magnetizing, non-ionizing, it's totally non-invasive. You can perform ultrasound in patients with implanted pacemakers, things that, for instance, you cannot do with MRI, and it's also very, very portable. You can actually see here a picture of an ultrasound machine on board the International Space Station. I believe they have 2 of them. And it's relatively inexpensive. Nowadays, there have also these handheld devices that you can essentially have in your pocket. And it's relatively simple to use. You can even train an astronaut to do an echocardiographic study. The view that we're going to be using, okay. The view that we're going to be using here is what we call the 3-chamber view. That's essentially a view that contains the inflow and the outflow tracts of the ventricle, and that's going to allow us to actually observe the transit of blood as it enters, flows through the ventricle, and exits the ventricle. And these are the type of images, the type of raw data that we're going to be using as input. This is essentially imaging that is performed as part of routine echocardiographic procedures in patients. What you see here is what is called a color Doppler echocardiography. That the color there is indicating the speed at which blood is flowing towards the transducer in red or away from the transducer in blue. So it's telling you that the flow speed of blood in the direction towards this point or away from that point. Okay. However, blood flow inside the heart is obviously not only in one direction; it's multi-dimensional, and knowing the flow only in the flow speed only in this direction, kind of tell us everything about this complex swirling flow patterns that we just saw a minute ago. So, in order to get a better idea of these multidimensional flow patterns, a few years ago we devised a method to analyze these images, which essentially are, again, images that you can get any day at any time from an echocardiographic machine. The only thing is typically you don't use such a wide sector here, so we're enlarging the sector a little bit to encompass the whole ventricle. So we take these images, this Doppler velocity, we pre-process it a little bit to take it to essentially only look at the velocity inside the ventricle and smooth it out a little bit, and then we consider that flow of blood has to conserve its volume, so blood cannot be created or destroyed inside the ventricle. So when we see the flow accelerating or decelerating in this direction, that actually means that blood is going to have to come from the sides or go away towards the sides. And we can write an equation that mathematically conveys that idea and use it to calculate the crossbeam velocity component, the velocity component that is in this direction. And we compose now this raw data with this data that we deduce to obtain velocity maps inside the left ventricle like this one. Okay? So what you see here is in black, you see these lines that are parallel to the two-dimensional velocity field in this plane at each instant of time. And with color, you see the magnitude of the velocity. So things that are red are essentially non-moving. And as you go up this color scale from yellowish to green, blue, and magenta, the speed increases. For those of you who are curious, this is actually my heart, which tells you how non-invasive this technique is, that we can actually try it on ourselves as many times as we want. Now, the question that we have to answer now is, let's say we have this tool that can measure the velocity field inside the ventricle. That still doesn't tell us about transport in a direct way. We know that velocity is high here during the filling phase of the ventricle. It's going to be high around there during the emptying phase. But it's varying in space and time, and it's very difficult from these type of images to actually know if there's going to be any region, any blood pool inside the heart that is actually staying there for a long time. So in order to answer that, what we do is we use this. We define a way to compute a variable that we call blood residence time, and this is going to tell us how long a blood particle stays inside the ventricle. Okay. Again, we wrote an equation for the evolution of that variable that we call residence time, that is essentially increasing as time goes on, with and is being carried by the fluid, by the flow. And what we do to essentially take into account that blood is coming fresh from the atrium here is to input residence time equal to 0 at this inlet here. And for this flow in this particular heart, you get in the same particular heart, you get this distribution of residence time. As you can see, these complex swirling regions that you see here actually generate quite a bit of mixing and allow to distribute the residence time of blood, and by redirecting the blood from the inflow towards the outflow. Okay. Now, we can calculate this for any patient, but it still is not telling us much about. If I show this map to a cardiologist, they can maybe say, well, maybe this is a little bit high here, but this is still not a number that is 1 or 0 or 2 or 3 that one can use to make a clinical decision. So on top of that, what we do is segment these maps to look for what we call residual blood pools, that essentially are regions inside the ventricle that have a high value of this residence time. And here you can see a diseased heart. Its residence time definitely looks higher than in this healthy ventricle that we saw in the last slide, particularly there close to the apex. There is this red region of blood that doesn't mix with incoming blood every cycle and doesn't get out of there. It stays there for a long time. So we would like to label those regions and describe them based on a number of properties, particularly their proximity to the wall, since the endocardial wall is going to be emitting chemical signals that trigger thrombus formation. We're going to be particularly interested in those regions that are close to the wall, and also if they move or deform. So we have an automated way to do that, and that's essentially what the result that one gets when one runs the segmentation tool. And so in summary, now we have a tool that uses as input data that you can routinely get in the echo lab any day in any hospital or clinic, and generate information that is that could be useful for a doctor to decide whether to anticoagulate a patient or not. Okay, and keeping in mind these additional constraints or considerations that one has to take into account when designing diagnosis tools, it's also important to take into account that our method does this analysis in about the same amount of time that this patient is going to be sitting undergoing this ultrasound test. So it doesn't really impose a large processing burden, that it requires very modest computing power. You can perform this type of analysis on this laptop or probably on an iPhone. We haven't tried, but I think it shouldn't be difficult. And it can be performed by an echotech. You don't have to have an on-site engineer to run this type of analysis. You can, anybody who has a little bit of training in imaging patients can do this type of analysis. Now, the million-dollar question is this type of method useful for anything or not? Can we actually detect thrombi? So we're working on a number of clinical studies to answer that question, and one of them is concluded recently, and this study was actually done in collaboration with our Spanish team at the Hospital Gregorio Marañón in Madrid, and we have a manuscript that is about to be submitted. So I'm going to summarize briefly the results from this study. I cannot get into the details because the manuscript hasn't been submitted yet, but I'll give you the gist of it, okay? So our Spanish collaborators recruited 73 patients consecutively admitted into their hospital for a first anterior acute myocardial infarction, which is essentially these large myocardial infarctions at the front of the heart that Dr. Kahn was mentioning before. That took them some time, but the recruitment is finished. And within 72 hours of their admission, they perform this type of imaging that we need to look at, detect, to look at the flow inside the heart and detect these potential pools of blood that do not move. And then they followed the patients at 6 months and performed an ultrasound with contrast agent to look for the presence of thrombi. Okay? In this particular cohort, there was an incidence of thrombi of 20%. Because these were large anterior myocardial infarctions, and the incidence of thrombi in this particular type of condition is relatively high. This is an example of the stasis maps, the residence times maps that we obtained in a patient, what we will call patient A, that was negative. This patient didn't present with a thrombus at 6 months. And this is the stasis map that we obtained for a patient that did present with a thrombus at follow-up. And you can clearly see that the residence time is much higher in the patient that had a thrombus than in the patient that didn't have a thrombus, particularly if you look at a segmentation of regions that have residence time larger than 3 seconds. This patient had practically nothing, whereas this patient had a relatively large region. And then you can see at 6 months, this patient didn't have a thrombus, and that patient there had a thrombus, okay, that you can see in these two views. Now, we performed this type of analysis for the 73 patients in the study, and we found that in that population, there was no significant difference in any other type of conventional echocardiographic index that these patients that are calculated for these patients when they are admitted. So EF is ejection fraction, is the fraction of volume of blood that is being ejected each heartbeat. That is between 65% for a normal. It can go down after a myocardial infarction. In this population, it was about 45%, so a little bit lower than normal. People also try to measure the deformation of the wall to try to get indices of how good the heart is squeezing. So we looked at that, no particular difference. But we did find a difference that was very significant for the properties of these residual blood pools, particularly for their size and also for the length of the perimeter of these blood pools that was in contact with the endocardium. And that all makes sense because this injured wall there that close to the region where the myocardium has been deprived of oxygen is going to secrete signals that are going to trigger coagulation. So it makes sense that these variables actually correlate with the presence of thrombi. And we actually found that using these variables as predictors of thrombus formation had a fairly good predictive value. So I don't know if you're familiar with this concept of area under the curve, but it's essentially going to tell you how close or how far away from tossing a coin you are when using a criterion as a diagnostic tool. And 0.5 is essentially tossing a coin. 1 is absolute certainty. We're getting something like between 0.7 and 0.8, depending on which one of these two variables you use. So we're pretty happy about this data because particularly right now there's a lack of criteria. There is absolutely no quantitative criterion to guide the clinical decision making about these patients. So the status of our project right now is that we filed a patent to protect this intellectual property. We are researching details about how to commercialize this as a product. We're forming a company, and we're seeking funds from the NIH and potentially also VC investors. And this is how we see the path to commercialization of our idea. So hopefully we'll get patent approval. We'll also seek funding from grants or investors. We will seek for FDA approval via 510K path. This is again a software method that analyzes non-invasively acquired images, so we don't really believe FDA approval is going to be a big barrier, but one never knows. And then the commercialization path that we envision will have two phases. The first one in which we will sell our product to a few luminary sites that will help us in obtaining further data to support the validity of this tool to predict thrombus formation. And that will help us get a reimbursement code that then we can use to essentially bill each individual patient for getting this type of images. And with that, I would like to thank you, and I would be happy to take any questions today with Dr. Kahn.
Thank you very much for that. Before we get started with the Q&A, I just wanted to take a quick survey of the audience. Us today. So students from UC San Diego, do we have any students? Wonderful. Thank you very much. What about entrepreneurs, investors? Raise your hands, please. Wonderful. Thank you very much for your support and being here. What about members of the general public? Are you just wonderful? Great. That's fantastic. Thank you very much. We appreciate you being here, and this is a forum that is meant to be open to all kinds of different folks and all different walks to really help us spread the word about these wonderful technologies that we're seeing here. So please, go ahead.
Thank you. Gentlemen, why don't you come join me here in the round table. So, well, thank you, gentlemen. That was a very informative and interesting pitch. I've seen it evolve, so this is getting better every time. I'd like to open this up to the audience. Does anyone have any questions at this point from the presentation? If not, sir.
So thank you for a very clear presentation. Not being a medical guy, even I understood many parts of it. How are you planning to package this in terms of taking it to trials, taking it to product? What's the processing power you need? Can you give us some idea about packaging it into a product, or is this all part of some alliance you're going to make with the ultrasound company?
Yeah, maybe I can start and you can add things and jump in as appropriate. So first of all, the nice thing about this compared to some other, there's a lot of interest in sort of applying these fluid dynamic principles to other areas in cardiology. Some of those actually involve very heavy duty processing power, and in some cases even supercomputers and things. This is, as Juan Carlos mentioned, the processing power is really quite modest. And so this, because it can be done on essentially any PC, it allows us the potential to have the software run on site, or it can be, and so that's not a big hurdle for us. We probably would seek to have the software run through, available through a cloud-based pathway, just to allow ease in terms of updating and things like that, but not for computational purposes. And then other things,
So the packaging would be in this first stage, where what we will be doing is try to convince the medical community to incorporate this into their practice. The idea is to essentially package this as a software application that they can run in their the computers that they have to read echoes.
yeah.
And that can, again, this I can run this on my laptop easily. And then at a second stage, we would have a number of servers in our site that would receive the data, would analyze the data in a really timely manner. Again, 20 minutes is enough, and then return the results to the clinicians.
And then, sorry, also you mentioned the question about whether this would be packaged with the Echo software as part of the vendors or be independent. And the models for both of those currently exist in clinical cardiology. Like, for instance, we've recently at UCSD purchased a third-party vendor package that does some post-processing on echoes that are done by all different vendors. And so, at least initially, we would like to develop this as software that could then accept data from any of the vendors, and that way be vendor neutral. But of course, we would be open to also considering partnership with vendors, and to me, it's a natural fit for that. And so,
It sounds like that may be the fastest path to commercialization for you if one of the vendors were to take it and put it in, because they're already doing a bunch of image processing in their machines.
right.
This would be an added feature to it.
Right. And that essentially, like, there have been, as Echo has evolved, there have been sort of these increasing types of analyses that have been added on to the echoes that have been done. And there were sort of models for this in the past, where things were sort of, a few years ago, one of the vendors came out with a type of analysis that was found to have a lot of utility. Then gradually the other vendors added it as well. And then also some third-party vendors then offered it with some additional bells and whistles, and now both of those exist. And so I absolutely agree that that would be natural.
Yeah, is there any special angle that the technician should be doing during the performance of the echocardiogram to give you a better analysis, or can you just take a stock echocardiogram and perform just as good an analysis versus anything specialized that the technician could do?
So, it would not optimally work with a stock echocardiogram. Because the reason is the type of image that Juan Carlos showed, where they actually put the color flow over the area of the heart that we're interested in, they just typically don't do that in routine practice. Would take 1 minute to do it. But it's just not one of their routine acquired images. And so we would have to ask them to do it, and it's in a conventional view that they're used to taking, and there's just a couple machine settings that they do to increase the frame rate and things like that, so we get good temporal resolution. But we would need the images to be acquired for this purpose, and we couldn't go back over, like, say, an echo. It'd be great for research purposes if we could use echoes from the past and things like that, but unfortunately that's not an option because people don't acquire the images that we need.
Okay, so this would require a change in the standard operating procedure of a technician in doing this?
No, not really. This is, so the view that you see there is what is called the three-chamber view. It's a standard echocardiographic view. Technicians are trained to acquire images in this view. The only difference is you see the width of that sector, of that Doppler sector. That's uncommon. So this color Doppler is typically used to look at flow through valves, or to look at septal defects, or to look at flow in very concrete regions. So they don't typically increase the width of the sector that much to cover the whole ventricle with color, because that decreases the temporal resolution. So the idea is if they want to look at, for instance, if there's a mitral regurgitation, they'll look very close to the mitral valve, or if they want to look at a septal defect, they will look close to the septum. They'll never enlarge the sector like that. But that's like, there is this knob in the ultrasound machine that you do a little bit like this, and that's it. And it's the same view that that they're trained to take.
Okay.
So
so they don't need additional. They just need to be this needs to be explained to them. They see it done once or twice, they would just be good to go. It wouldn't require extra training, and the machines have all the technology to take the pictures.
Okay, thank you.
I have a question. So in this alpha stage of the software, how long does it take for the software analysis to take? How long does it take for once you acquire the image? Is it 20 minutes, 10, a half an hour, an hour?
So the first stage that involves computing the velocity field takes about 10 minutes. And the second stage that involves looking at the transport, that velocity field and the mixing and looking at these blood pools that are not mixed, takes another 20 minutes or so. And there's definitely room for optimization. We haven't really looked at how to make the code much faster as of yet, because we're quite content with those 30 minutes.
So in 30 minutes after taking the echocardiogram, you can run and get a diagnosis of the level of stasis within those 3 seconds. And the time, just one more question, the time that you have to take the echocardiogram, how long is there a minimum or a maximum amount of time? Just the regular amount of time that people use?
You mean how much longer does it take to add these images?
No. When you're doing your regular echo, right?
How long does an echo take? Is that what you're saying?
Yeah. Do you need to add time to it? Do you need to modify it?
A typical echocardiogram is about 30-40 minutes or so. And so this would, and then if we then said now we want them to take this picture, it would add 1 minute.
I have no technical ability with a computer, but let me ask you this. In the image where you have the green flow up above, does your algorithm convert that to a number?
Yes. So it will measure the area of that region. Okay. It will measure how close it is to the wall of the ventricle. It will measure how high the residence time is inside that region. And all those parameters are actually predictive of thrombus in the pilot clinical study.
Now, why can't the computer do that with the smaller picture? I mean, why do you have to expand it? So, can't the computer do it in the smaller image, the same thing, or not? You have to expand it to get the color in it or something?
Which, the one at the bottom?
Well, you say you have to widen it to get the bigger image.
Oh, because you see, transport is a global phenomenon. So if you look only at what happens at a certain point, you don't really know where blood is coming from and where blood is going to.
Okay, so the algorithm actually has to see the picture. Okay, well, we're good. Maybe I'll go into computers.
Yeah, I think to clarify, it needs to see the entire ventricle so that you have conservation of the blood coming and going.
Can you give us some idea about the financials, how much you're looking to raise, and what would you charge for that? Have you thought of that at all?
We're definitely in the exploration stages of this. I think the way we sort of put this into context is to sort of think about what is the cost of an echocardiogram and what is the cost of other sort of post-processing software and things like that. The echocardiogram, I think varies. These are payer dependent and some whatnot, but on the scale of $500 to $900, something like that, I think is. And then these other post-processing software, we know of one that is recently been developed, for which there's a lot of interest and has an application for cancer, evaluating people who might potentially have early heart damage from cancer. And I think people are talking about charging about $200 for that, and that's a technology that UCSD recently purchased. And then
Per test.
that's per test, just as a sort of approximate number. Obviously, this is something we would have to, do some research on. And then the question is, how much money would we need in order to make this into a product? I think, obviously there'll be a series of stages, but to do it as an initial development, we would need, significant funding to go through the FDA process and funding to also convert this alpha product into sort of a nice product that can be, used by a sonographer, and do some early additional testing. Should we share the sort of? The rough number that, and again, this is sort of just early sort of ballpark, would be about $2 million to sort of get this off the ground. And the way we look at this is really, we see this as sort of the potential for this is we think is really huge because we're dealing with heart disease, heart attacks, and heart failure, which is just such an incredibly common things that are, and these echocardiograms are done so many times every day all across the country in every city, and such a large patient population that if this has the potential that we think it has, then we think there's really a very large potential market. But of course, it will take some time and take some data to realize that.
I just want to add also that the goal of this Insight Innovation Series is precisely to bring to you breakthrough innovation, really novel inventions that are happening at UCSD that are not quite fully in a commercial stage. And as it is obvious from the answers and the questions, that's where we're at. So that's exactly what we're trying to facilitate. So your questions, and I think, are very welcome and very good for the audience here. And maybe later we can hear a little bit, if you guys want, from Ted, and maybe he has something to add. But there's another question right here, and then one in the back.
So this is an age-old problem from a cardiologist standpoint, I believe, and applying fluid dynamics engineering to it should have been a common sense for a long time. What's the genesis of the idea that you guys got together to say, this is how we should go about solving this, and that nobody else thought of it?
So one of the deal breakers here, I think, or the deal makers, was our ability to measure flow in the left ventricle with this ultrasound processing method that takes the color Doppler image and makes a velocity field out of that.
That has been solved in many other fields. That this type of measurement is being done in many other fields.
Yes, but remember that color Doppler only gives you a velocity component in one direction. So you're only going to, so that red and blue colors there are telling you how fast or how slowly blood is moving towards the so if you put the transducer here, right, you listen to the Doppler signal of the blood going towards the transducer or away from your transducer, but you don't know anything about these other directions, right? And that turns out to be important in transporting blood. So we had this idea about 5 years ago to use this principle of mass conservation to calculate the missing velocity component from the one that we can measure. Once you have that flow velocity field that is full on that plane, you can think about many things that you can do with that. And transport is one of them. We've been measuring other variables more related to physiology. So we've been looking at how these rotational motions contribute to pulling flow from the atrium. We've been doing more, in the past we've been doing more physiological type of studies, but this one actually has a huge potential to help diagnosis. But I think what makes this possible with this technique is the ability of having something that is fully non-invasive, that doesn't require injecting anything into the patient, doesn't require putting the patient in a magnet for 40, 50 minutes, and that is almost real time. That was not available 5 years ago.
Who approached home? Did you approach? Actually together.
How did we get together? We've been collaborating for a number of years, and again, I think I should also emphasize that although there are two of us here, there's also other collaborators in Spain who've also been involved in this. So it's really, I think, a sort of common ground that we came to, and we've been sort of interested in the idea of exploring intracardiac flows, and that there's valuable clinical information to be had there. And, to be honest, we're actually interested in other applications beyond this. Of once we can sort of understand more about the blood flow of the heart, we think that there are other ways that knowledge can be used clinically.
Two questions. First, if you had additional data from a few hundred other patients with these images and outcomes data, do you think you could improve the algorithms? And second is, how does the results of your algorithm compare to simply the ejection fraction?
Right. Certainly we are very eager to have additional data, and I think we are, because we're in the early development stages, and we have a lot of power to sort of to measure all these different quantities. The question that we need to, be sure we determine is what are the important what are the important variables that we calculate, and certainly having some additional data will be useful for that. And then, of course, an additional step when we do that would be then to validate that. So for example, we've done this study in 73 patients. We would then, like to replicate that and not develop it, but then test it, and then increment, and then refine the algorithm, and then do sequential validations. So we do see this as an evolving and improving tool, and then we can get those numbers even closer to 1. And then the other question was.
So I can give you an example of an improvement that we've already done in the algorithm over the time that we've had this data from the Spanish study. So one of the things that we realized is that the ultrasound signal tends to be low, close to the apex. So we get low velocities that are sometimes lower than the floor level of the imaging device. And that essentially was overestimating blood stasis. So what we did is we went back and we changed the algorithm to work with acquisitions performed with 2 different scales. One that is higher and works close to the base of the ventricle, and that then is merged with another acquisition performed with a lower velocity scale that works better to resolve those low velocities. And that improves the specificity of the method.
I think his other question was, how much better is your algorithm
Right, to the ejection fraction. So, yeah, and this has been, and so it turns out the ejection fraction, which again, just to remind everybody, that's what fraction of the blood the heart ejects or during each heartbeat, is a relatively crude measure of heart function, because it only measures the global function of the heart, and there are I could show you hearts which have the same ejection fraction but have very different properties and would have very different residence times and areas of stasis. And so this is far superior. And in the Spanish study, the ejection fraction was not predictive. And
Actually, the ejection fraction didn't discriminate, was not able to distinguish between patients that had.
I have a couple questions. The first one is I was interested to know if there are other universities presenting similar types of inventions to yours. We always look at competition when we're developing something. And the second question is more to the cardiologist. There are issues from the treatment protocol that you have with blood thinners. Warfarin requires measurement, and there's complexities with that, and some of the new blood thinners have issues of their own. Do you know if there's any new blood thinners coming down the pipeline?
Okay. Why don't you first, you want to talk about the competition question?
Yeah, so there's, this is a relevant problem, so other people are interested in it. There's a couple of other ways to look at, to obtain the flow velocity fields that would generate what would allow you to calculate these residence time indices. One of them is based on performing magnetic resonance, but that so far hasn't had enough throughput to actually generate enough information or clinical data. I'm not aware of any group that is using magnetic resonance to pursue this idea of the residence time. And there's other efforts that are based on using CT scans to obtain a good representation of the geometry of the wall of the ventricle, then use that to simulate the blood flow inside the ventricle, and that is then not measured, it's really simulated in a computer, and from that infer the residence time. The problem with that is, first of all, you have to expose the patient to a lot of radiation to take a cardiac CT scan. It's not something that you're going to be doing on any patient every year or every other year or something like that, unless they're really old, which then I guess it doesn't matter. And yeah, I think that is the. But anyway, and this simulation process of the blood flow prior to actually being able to calculate the residence time is really expensive. That's the kind of simulation you need a supercomputer to achieve, and also extracting the geometry of the walls from that CT data is very user intensive. So and that's, I think, the reason why those efforts have been hampered, and they have not arrived at getting anything close to a tool that you can apply routinely to patients like we have.
And then to answer your question about blood thinners, first let me remind other people, in case they don't know what you're referring to in terms of the different types of blood thinners. So the traditional blood thinner is called warfarin, also known as rat poison, and blocks the formation of the clotting factors in the body. Now, that, as you alluded to, that is a sort of challenging medicine to take in a lot of ways. And we sort of view it as a dirty medicine because it has a lot of interactions with other medications. It also has a relatively narrow therapeutic range. If you take and the dose that's right for a given person is variable from person to person, and we don't know it ahead of time in general. So it's very challenging and it requires monitoring. People have to get their blood checked, and typically, initially, when they first start on it, about once a week, but then once they're on it, about once a month. And now there are millions of people on this medication, and it is used commonly, but it does have these issues which are quite significant. Now, there are these newer agents, they so-called NOACs, N-O-A-C, novel oral anticoagulants. And there are 4 of them that are FDA approved, that are on the market now. And these are being really have taken off very rapidly in the last 5 or so years. And we're using them more and more, really for a large number of patients for whom we previously treated with warfarin. And these medicines don't require monitoring, they don't require dose adjustment, they seem to be safer with less bleeding, at least based on the initial studies. To a little bit, and at least one of the medicines also has an antidote that is available that is FDA approved. Although in practice, I haven't seen this needed much because these patients generally do very well on them. And whether there are additional medicines in the pipeline beyond those four, I would think there are, just because this is such a huge market from a pharmaceutical perspective, but I don't know the details of this, and I don't know if there are others coming.
Hey, Andy, if I could just add, and just to make sure these clarifications, but talk about the millions of patients that are on warfarin and the success of these new next generation anticoagulants in the market, and yet those drugs are not being prescribed in general to the patients we're talking about here.
That's correct. Right.
So they're not part of the normal protocol for this very large set of patients that we're trying to address.
Exactly. And we don't have experience using those medications for the treatment of blood clots in the heart. There's no data because those medicines were developed specifically for largely for people with atrial fibrillation. This heart arrhythmia. And so that is where the clinical data is, and so that is where doctors prescribe them. And that is the largely the indication for which they have FDA approval. And so, for example, I showed you an example of that patient I had earlier who had a blood clot in his heart. I didn't put that patient on those medicines because there's no data to show that they work. They might work, but the clinical experience, and it's not great data at all, but there is some data and some experience using warfarin, and so even though there's, we use that in that situation, but then if we're trying to prevent a blood clot and identify these patients, we really think that this is an opportunity for these newer agents, and we think they likely would be a good fit, but ideally we would seek to prove that with some data.
Hi, great study and great work, by the way. Thanks for the presentation. I have a question about the, I guess, do we have any correlation at all so far to, let's say, a leaky valve or, I guess, enlarged heart types of syndromes regarding the flow rates at all? Or the reason I'm saying is it might open up a little bit more potential use cases.
Yeah, I mean, we should talk about it. I mean, I think this is a great question because these are clinically very, very important, and the idea of treating valvular heart disease is clinically really one of the things that's at the forefront of cardiology right now, because we're having new ways of treating that. We used to be sort of valvular heart lesions were largely could only be treated with surgery. And in the past few years, we've had new treatments where they can be treated without surgery. And so there's a lot of interest in trying to evaluate these patients and identify them and sort of classify them and so on. And looking at the flows would definitely be something that would be of great clinical interest. You want to say more about
that? Any more questions?
At the beginning of your presentation, you talked about with arrhythmias also need to have anticoagulation therapy as well. Now, this particular technology specifically looks at patterns and images of the ventricle or the flow through that ventricle, and the patient at the time of the echocardiogram may or may not have an arrhythmia. So there's no way to really address that with this technology, I understand, correct?
I partially disagree with that statement. Okay, so it is true that that we're not looking at the flow in the atrium, and it is true that it's hard to know if if a patient doesn't present with arrhythmia, if what you're seeing is actually indicative of what's going on. However, I just came back from AHA, where my Spanish collaborators used this method to show that patients with atrial fibrillation have increased residence time in their ventricle as well.
Well, because there's deeper too, but that's...
No. because a patient that has atrial fibrillation doesn't have what is called the atrial kick. So if you're a little bit familiar with how the ventricle fills up, there's this early relaxation phase in which your myocardium relaxes, the pressure inside the ventricle drops very fast, and that essentially opens the mitral valve. It fills with about 80% of what's going to enter the ventricle. Well, it depends on a number of factors, but let's say 80% in a normal individual. And then, while the ventricle is filling, the walls extend. That increases the pressure inside the ventricle, and that closes the mitral valve. And it's going to stay closed for a while. And during that time, the atrium fills a little bit, and then when the electrical contraction impulse fires, it actually fires in the atrium, and that makes the atrium contract, and it's going to push all that blood into the ventricle that accounts for the remaining 20%. In a patient that has atrial fibrillation, that atrial kick doesn't appear. So what happens is that sloshing motion in the ventricle during diastole, during filling, that happens first when the ventricle relaxes, it's going to move blood a little bit, and then when the atrium contracts, it's going to push blood a little bit more. So if you're missing that, it turns out that your residence time in the ventricle is significantly higher. And we actually don't know. I don't think there's any study that has shown in patients that are undergoing atrial fibrillation and had a stroke. It's not clear where the thrombus was formed. If it was formed everybody suspects the left atrial appendage because it's a region that is a little bit separated from the flow. But it's not clear that it actually, there is no data proving that it actually comes from there. It may also come from the ventricle. And furthermore, there's recent clinical data indicating that patients that have strokes, patients in atrial fibrillation that have strokes, usually have strokes when they're not fibrillating. So it's not even clear that there's temporal, in situ temporal correlation between atrial fibrillation and stroke. So this whole idea has been revisited. I'm pretty sure Andy can tell you more.
No,
about
I mean, you actually brought up something that's really of great clinical interest and to both of us, and this is the idea of trying to take similar ideas of analyzing cardiac flows and apply it to atrial fibrillation and to risk stratify those patients. This is something that affects millions and millions of people in the United States. And so right now, when we have patients with atrial fibrillation, and we're trying to decide which of those patients we put on blood thinners, with all of the risks and baggage that we talked about with those blood thinners, the way that decision is made in clinical practice is by coming up with a scoring system for that patient. And that scoring system is based on a cohort of patients that was studied years ago and trying to apply that to that patient. It's not looking at that patient's heart. It's looking at how old the patient is, looking at the gender of the patient, whether the patient has high blood pressure, whether the patient has vascular disease, whether the patient has heart failure, and things like that. So it's a series of risk factors, but it's not actually specific to that patient's heart. And you might imagine, given the types of flows we showed and the images we showed, that you could apply a similar type of analysis, and what you really ideally like to do is to look at that patient's heart in particular and apply it to, well, what about that heart, and what is the shape of that heart, and what is the nature of that heart's flow patterns? And that is not being done right now. Instead, we're sort of using this sort of broad brush, previous data set, which I feel as a clinician is really rather crude and unsatisfying, and just it's sort of an integer scoring system: 0, 1, 2, 3. If you're 0, no. If you're 2, yes. If you're 1, we don't know. That's really what the guidelines tell us right now, and so we would like to make that more patient specific as well, and seek to do that.
We're gonna. It looks like we have a couple of more quick questions. We're going to ask our speakers to stick around. I'm really happy about the level of interest that this is generating. There's food outside waiting for all of you. That's my main concern. I want to make sure it doesn't get cold. So Dave, do you want to close it up and wrap it up? And do you have some questions?
No, my prompt questions all got asked, so I appreciate everybody's attentiveness and interest in the technology. We're welcome everybody to stick around and introduce yourselves personally and ask any questions that you still have. And please join us for some food outside. And just next door there's a what was it, no host bar?
It's a cash bar. Yeah.
Wine and beer.
You can buy
So we welcome you to stay, and we've got the property for another 45 minutes or so.
Correct.
Thank you.